All right, let's talk about a real puzzle. Imagine you get a case that looks like one thing, then another, and then something else entirely. Today, we're on the hunt for a true master of disguise in sinonasal pathology, HPV-related multiphenotypic sinonasal carcinoma, or HMSC for short. And let me tell you, this isn't just another diagnosis, it's a genuine challenge that really tests our skills. So here's the situation. A sinonasal biopsy lands on your desk. You look under the scope and you see features that are all over the place. There are glandular bits, maybe some squamous areas. So you're thinking, is this adenoid cystic or is it a squamous cell carcinoma? The problem is there's so much overlap, and that first look can be incredibly confusing. And this is where we meet our culprit, HSC. We call it a diagnostic chameleon, and for a very good reason. It's a high-risk HPV-related tumor, and it's famous, or maybe infamous, for its ability to look just like other, more common sinonasal cancers. It's a classic pitfall you've got to watch out for.
So, to really get a handle on this thing, we first have to appreciate just how varied it can look. In this first part, we're going to dive into exactly why this tumor is so tricky to pin down based on its morphology alone. The biggest clue is right there in its name. Multiphenotypic. Now, what does that actually mean? It means the tumor shows off multiple, totally distinct looks. In a single biopsy, you can find areas that look like they belong to completely different tumors. And we're not talking about subtle changes here. It's like having several different cancers all rolled into one. Okay, so let's go down the microscope and see this chameleon in action. We're going to check out all the different histological patterns HMSC can throw at you. You're about to see just how convincing its disguises can be. Now, check this out. The contrast here is just wild. On the left, you've got this classic cribriform glandular pattern that just screams adenoid cystic carcinoma. But then, in the very same tumor, you find areas like the one on the right with obvious squamous differentiation, even keratin pearls. This two-faced or biphasic nature is a dead giveaway for HMSC. And oh, the disguises don't stop there. It can also show up with these solid basaloid nests that have that peripheral palisading, making it look like a basaloid squamous cell carcinoma or even a cylindroma. So you can see how easily you could be led down the wrong path if you only have a small biopsy to work with. And just when you think you've seen it all, some cases of HMSC will throw in these spindle cell or sarcomatoid areas for good measure. I mean, if you saw this part alone, you might even start thinking about a sarcoma or a carcinosarcoma. This incredible variability is exactly why just looking at the morphology isn't enough. But okay, amidst all this chaos, there is one really helpful visual clue to look for, and it's one of the tumor's most telling features, the presence of overlying high-grade surface dysplasia. Something like 70% of cases have this, and it's a huge hint that you might be dealing with an HPV-driven process, and specifically HMSC. So, since the visuals alone can be so deceiving, we have to dig deeper. We need to look at the tumor's molecular fingerprint to really unmask this imposter and get to the right diagnosis. This is where our ancillary studies, immunohistochemistry and molecular testing, become absolutely essential. So, what are the absolute non-negotiable criteria for this diagnosis? Here's the essential checklist for HMSC. First, its location. It has to be in the sinonasal tract, period. Second, it has to be positive for high-risk HPV, and it's very often type 33. Third, it has to have that mixed multiphenotypic appearance we just saw. And finally, and this is crucial, it has to be negative for gene rearrangements like MYB. The immunoprofile really tells a fascinating story here. That strong diffuse P16 positivity is our big flashing sign for high-risk HPV. Then you have stains that light up both sides of its personality. You've got myoepithelial markers for the glandular parts, and you've got squamous markers for the other. And just as important is what it's negative for, specifically MYB, which is key to ruling out ACC, and it retains INI1, which helps us rule out SMART-CB1 deficient carcinomas. Okay, I know this is a lot to juggle, and it's easy to feel a bit lost in all the complexity. But the good news is, there's a clear, logical, step-by-step path to follow. So let's walk through the diagnostic algorithm that cuts right through all the confusion and leads us to the correct answer. And here it is. This flowchart is our roadmap. It gives us the systematic approach we need. See how it starts with a broad category, a sinonasal tumor with adenoid cystic-like features. And then it just uses a series of tests to narrow down the possibilities until there's only one answer left standing. So, why does all this matter so much? Why is it so important to get this specific diagnosis right? Well, because it has huge implications for the patient. Separating HMSA from adenoid cystic carcinoma isn't just an interesting academic exercise. It directly affects the patient's prognosis and their entire treatment plan. We absolutely have to get it right. Let's break that algorithm down into 5 simple steps. 1, you start with a tumor that looks like ACC. 2, your first move is to screen with a P16 stain. 3, if that comes back block positive, you move on to confirm with specific high-risk HPV testing. 4, and this is the critical step, you have to exclude a MyB rearrangement. And 5, once that comes back negative, you can confidently, definitively diagnose HMSC. All right, to really bring this all home and make sure these concepts stick, let's do a final lineup. We're going to put HMSC side by side with its most common lookalikes to really hammer home the definitive features that set them apart. This little table sums it all up perfectly. Let's just go column by column. For HMSC, you've got positive high-risk HPV. That's a hard negative in ACC and SMART-CB1 deficient carcinoma. The molecular driver for HMSC is HPV, right? Totally different from ACC, which has the MYB fusion. And the key distinctions tell the rest of the story. HMSC often has that surface dysplasia, which ACC doesn't, and it holds on to its INI1 stain, unlike a SMART-CB1 deficient carcinoma. Look, if you take away only one single thing to help you separate HMSC from its mean mimic, let it be this. HMSC is defined by being HPV positive and MYB fusion negative. Classic adenoid cystic carcinoma is the exact opposite. It's HPV negative and driven by that MYB NFIB fusion. That right there is the definitive fork in the diagnostic road. And you might be wondering who actually gets this. Well, the clinical presentation is incredibly broad. It's been seen in patients as young as 28 and as old as 90, with a bit of a tendency to affect men more often. So this is a diagnosis you really have to keep on your radar across a huge range of adult patients. So, we've unmasked HMSC. It's a perfect example of how morphology, IHC, and molecular diagnostics all have to work together in concert. And it leaves us with a final thought, doesn't it? What other diagnostic chameleons are out there in our daily practice, challenging us to look closer, to think deeper, and to follow the evidence, wherever it leads, to get to the right conclusion?